Good afternoon. Thank you so much for the kind invitation. You have all the regards from Professor Parisis. I will be presenting a case of acute heart failure. It is about a 76-year-old male presenting at the ED, complaining of dyspnea and fatigue since 3 days before. He was obese and a former smoker. He had a history of COPD, 50 packet years. He had a poor functional capacity, and he was receiving metoprolol, 50 milligrams twice a day. The blood pressure was kind of low, systolic 86 and the diastolic 52. His heart rate was 50 beats per minute. His respiratory rate 28 per minute, and the saturation was 89 in room air. From the clinical examination, he had jugular vein distension, peripheral edema, and diminished breath sounds, and he was wet and cold. The ECG showed atrial fibrillation with slow ventricular rate. So our patient had at least 3 clinical signs of acute heart failure: hypoxemia, signs of systemic congestion, and signs of low cardiac output state. So we decided to have a quick echocardiogram in order to assess the function of the 2 ventricles. And it seems that the right ventricle was dilated and with a mildly impaired systolic function. He had a moderate at least tricuspid regurgitation. And we can see the typical D shape of the left ventricle, suggestive of pulmonary hypertension. And from the abdomen echo, we have ascites. So we have a patient with acute right ventricle failure, and what should we do next? It seems that the first step is to assess the severity and hemodynamic and provide hemodynamic and respiratory monitoring and support to the patient. And this means by clinical evaluation, the blood pressure, diuresis, and the mental status, biochemical evaluation, lactate liver markers, renal function, the BNP and the troponin, some imaging, echocardiography, and sometimes a CT scan in order to exclude the acute pulmonary embolism, for example, or even invasive evaluation, something that is very difficult in the emergency department. And of course, we must, according to the current guidelines, we should provide oxygen to a patient with hypoxemia, a saturation below 90% or a partial oxygen pressure below 60. And if this doesn't work and the patient is very in great distress, we should apply non-invasive positive pressure ventilation, but with caution in patients with right ventricular failure, because we will increase the afterload, and this could be detrimental for our patient. This is the biochemical evaluation of our patient. So he had markers of acute right ventricular failure, like increased lactate levels with very high values, 70,000, and elevated NT-proBNP. No. It's okay. The lactate level was 2.8, and the NT-proBNP was 70,000 picograms per ml. And he had also elevated values of troponin. He had normal liver values, but abnormal renal function, and the D-dimers were normal. So the next step was to identify and treat causes and triggering factors. According to the current guidelines, you will have to exclude these conditions known as CHAMPIT. And we have to keep in mind all these different diagnoses. And as our patient had the negative D-dimers and he had no signs of ischemia on the ECG, but had signs of chronic pulmonary hypertension from the echo, we suppose he was an acute decompensation of chronic pulmonary hypertension. So the next step was to optimize the fluid status. If the patient has a volume overload, one should give diuretics, furosemide at first, and then double the dose if this is not enough, or use combined diuretic therapies like metolazone. And if this is still not enough, you can provide the patient with renal replacement therapy. But if the patient is dehydrated and he has a low CVP, cautious fluid, we should give fluids cautiously. So we gave our patients furosemide 40 and then another 40 milligram of intravenous bolus. But our patient had also low blood pressure, so we had to maintain the arterial pressure and to increase the pressure and the vital organ perfusion. And according to the guidelines, we could give a vasopressor, preferably norepinephrine. Except for norepinephrine, one should think about giving inotropes in order to reduce the cardiac filling pressures like levosimendan, dobutamine, or milrinone. And this will improve peripheral perfusion and maintain end organ function as well. We gave our patient norepinephrine and dobutamine. So in conclusion, as a take-home figure, when we manage patients with acute right ventricular failure, we should first exclude acute coronary syndrome with nerve involvement and an acute pulmonary embolism. Then, if this is not the case, we should optimize the fluid status. And if there is peripheral hypoperfusion and hypotension, we should think about giving vasopressors in combination with inotropes. And if all of these measures are not enough, we should consider about providing mechanical circulatory support or renal replacement therapy, or even in sometimes palliative care. Thank you very much.
Thank you very much. Konstantina, questions? Yes, right ventricle. Not so frequent, but you need to be really expert to manage those patients. Yes.
Thank you very much for your presentation. I was just wondering about the 3 inotropes that you listed, like milrinone, dobutamine, and levosimendan. And your patient got dobutamine. Like, is that the standard of care in your clinic? Because we always have the same discussion with these patients, like which inotrope to give. And some say like levosimendan has the best data for like right ventricle, and maybe you can comment on that.
Yes, it seems that we gave the worst choice for the patient. I think levosimendan and milrinone is much better for the right ventricle, but it is they are more difficult to give it in the emergency department. So we gave what was possible in the emergency department, and then the patient was transferred to the coronary unit.
Yeah. Again, to make sure that we are all on the same line, what we wrote on the recommendation just before the ESC guidelines is there are 2 things to do when there is a right ventricular dysfunction with hypotension. Try to not give too much fluid, a little bit, but not too much unless you have congestion, and you quickly give vasopressor. And we said inotrope are only in few patients where you have clearly an evidence of low cardiac output. And then, as you said, we can choose whatever. But first is minimum of volume and vasopressor to improve coronary perfusion and other perfusion. Other questions? No? Konstantina, thank you so much. Thank you very much.